Good evening and a very warm welcome. My name is Maneesh Bhatia. I hope you can see me and you can hear me. Today, we are going to go through our next, that is number 18th Master Techniques of BOFAS. And we have today a great topic in terms of golden nuggets in ankle arthroplasty to be delivered by our European friends and colleagues, two surgeons who have a wealth of experience, and they are going to share their knowledge and experience. The theme we have selected for tonight is complications. So the first speaker will be talking about how to plan and how to avoid complications, whereas the next speaker will be talking about how to manage the complications if they happen. And then after the two talks, there will be time for discussion where you can pitch in and ask questions in the chat, and we'll try to go through all your queries. So without delaying it any further, I would like to introduce our first speaker, Kris Buedts, who is based in Brussels. He's immediate past president of IFAS. He is based at Foot and Ankle Institute in Brussels and is quite passionate about handling complex ankle and hindfoot work. He enjoys training young orthopedic surgeons across the globe. So if anybody wants to visit Kris, you're welcome to liaise with him. And one thing which I didn't know, out of ankle arthroplasty, I've noticed that Kris was a competitive swimmer, which is amazing. And I know he has an excellent interest in music and culture. So all these attributes, but today we are going to focus on ankle arthroplasty, and Kris will talk about how to plan and how to avoid complications. So Kris, if I can invite you to share your presentation, please. Thank you.
Okay. Well, thank you, Maneesh, for this kind introduction and for the honor to be present at this BOFAS webinars. I hope you can see my screen, you hear me. So I was asked to talk about complications in total ankle, that's the topic, but how to avoid them. So I'll try to give my visions on it. Those are my disclosures. But if we, first of all, it's an educational presentation. It's case-based, so you see my x-rays or what I've encountered. All patients, they sign a consent, but please use them only for educational purposes. Do not use those pictures in your presentations, because sometimes patients, they see it or other doctors, and it could be a problem GPDR-wise. Now, if you go to total ankles, it remains a complex and demanding procedure because we are treating younger patients, and unlikely with the other joints, there is more post-traumatic deformity because it's mostly due to previous rotational traumas or recurrent sprains. So you're at one side treating younger patients, so the implant has to survive longer. You are treating deformities in the same level. So it makes it a bit of a complicated situation where you sometimes have impaired structural integrity of the ankle joint that can alter biomechanics and stability. And the deformity can be as well axial as in the sagittal and the coronal plane. So that makes it sometimes a hard nut to crack. It can be a complex intraocular and surgical procedure where you have to take into account not only the lower mechanical axis, but also the mechanics of the subtalar joint, the talonavicular joint, and the subtalar joint, where you can encounter all those articular anomalies extra-articularly, but also intra-articularly, but also sometimes soft tissue imbalance. And also taking account that always the deformity is not always as we think at the level of the ankle joint, but there's also a knee and a hip that is standing above or more proximal from the ankle joint. So if you look at them at the mode of failure, most common will be still the aseptic loosening and a subsident, about 10%, where we're doing not so good as in the hip, where there's only 2 or 3% at 10-year follow-up. And that means that there is probably a problem of initial stability. There can be a design problem of your geometry. You can have swell shielding or malposition or malalignment of the implant. And at the end, if you have those problems, 70% will be a risk of reoperation. Is there so a way that you can deal with it? I try to explain the experience, but first of all, sometimes we cannot deal with it. This is a cadence prosthesis that I put in a couple of years ago. And at the end, if you follow up those patients, you see a fracture of the mechanical components or the metal components. So this is not due to your implant failure, but probably to your position planning, but probably is an implant failure, meaning that our implants sometimes are not still good enough and we can still work on it. And if you're going about thinking about the implant, you have to know your basic. When you use an implant, you have to know about tribology, about friction, wear, and lubrication, and what implant that you use. So the cobalt chrome alloy provides a hard and durable and corrosion-resistant surface, but it may contribute to stress shielding because of the Young modulus. Hydroxyapatite coating can enhance osseointegration, while titanium-based and porous materials reduce stiffness and mismatch and improve load transfer. Ceramic coating was used for a while and then reduced wear, but was associated with higher reoperation and cyst formation. So you need some basic of implant because if you use an implant. And there are a lot of implants on the market. They are different geometry, they have different coverage, and they have different designs. And at the end, you have to make a choice between stress shielding and versus stability that you want to achieve in your implant. And also, you need to know the different sizes to compensate for post-traumatic defects. Because if you have a case like this where you see a bit of a posterior malfracture, if you have only 4 choices of tibial implant, you know that you will have a problem if you cannot cover the complete tibial side of your deformity. At the second stage, then you have the patient. It's at the patient has osteoarthritis. There's an age, there's a profile of the patient, you have comorbidities, and you have also what the patient expects for your surgery. And that's why we developed a kind of a flowchart or a stratification plan in Brussels, where we used for our complex surgery, where we're looking at the patient profile. It's better than what the anesthesiologists use with the ASA score. It's more focused on foot and ankle, looking at the current health state of the patient with the smoker, vitamin D, obesity, alcohol use, diabetes, peripheral vascular disease, and we score them for every point. And you see also there's a psychosocial that we try to see if our patient is capable of doing the rehab that is requested for the deformity, but also the way that you can communicate with your patient can be important, that you understand what has to be delivered. And if we have a low-risk patient, so we don't modify, we use a standard protocol, a standard planning. But if there is a moderate risk, we're trying to optimize the modifier factors, looking at diabetes, looking at smoke cessation. But also we probably will use more robust implants, and we have a closer follow-up of those patients. And if you have a high-risk patient, then we try to consider conservative treatment, or we consider staging or surgery, adaptor fixation, that we use more robust fixation or more robust implants, and looking at a more aggressive infection protocol and probably longer non-weight-bearing protocol for the patient. So what if you see then about osteoporosis? Osteoporosis, you need more probably stable metaphyseal fixation, but it depends on the compact of the bone. So if you have an intact cortical rim with good calcaneus bone, then probably you can use a primary total ankle. If you have minor cortical thinning or cyst defects, then you have probably osteopenia or small cyst, then you need a short metaphyseal stem, or you can use a primary fixation of your implant with PECs and bone grafting. But if you have segmental metaphyseal loss, then you need stem extension and augment on your stems to get a primary stability of the ankle joint. But what then about obesity? So obesity increases load, but there is no stiffness mismatch. There is stress shielding depending on the stiffness mismatch and load, so it's not BMI alone. A stem does not reduce stress shielding, and it may worsen proximal bone unloading. So it's more important to have a lower stiff material or an axial interface fixation, like tri-D printed porous surface. But a stem fixation is probably not necessary because you can have more stress shielding of the implant and faster loosening of your implant. What we fear the most in complications is probably wound healing and infection. So how we deal with it is trying to have an adequate soft tissue handling. Think about the incision that you make and where you make it. In pre-op, you try to optimize the modifiable factors like vitamin D, diabetes, and smoke cessation. And at induction, we will use, as probably as everybody, antibiotic prophylaxis, tranexamic acid, but we also give a high dose of metiprednisone at induction, like 150 milligrams of solomedrol, so that we prevent the per and post-op swelling and give a better pain control for your patient. And we try to convince our anesthesiologists to have a core temperature at 34 degrees because it's the only modifier factor in surgery that is preventing for infection. We know that's a quite difficult deformity, so you need sometimes you need multiple incisions and you need additional surgeries. That means that as a surgeon, you have to know your surface anatomy. You know to have where your nerves run, where your tendons run, so you are able to prevent painful neuroma or tendon lesions when you do your surgery. And that's why we train our fellows to have Passepartout incisions. Passepartout means that the same incisions that you can use several times and a safe access to the joint. And at the end, what you want to use with your incisions, you have to have a good access to the ankle, debride soft tissue, and release it, and you reduce the tears in the mortise. And we typically use 3 incisions when you do a total ankle. You have the anterior incision, the posterior medial incision, and the lateral incision, and you see all the most common structures that are at risk if you use those incisions. In the posterior phase, we will use a compressive dressing. That means that before we do a cast, we actually use a very compressive dressing to prevent swelling, and we adapt our non-weight-bearing protocol depending on the profile of the patient that we have in front of us. Now, interesting enough, if you go into surgery, then we see that mean 50% of all total ankles need at least 1 additional surgery. And if you treat post-traumatic arthritis, it goes even up to 70% that you need additional surgeries to be able to correct the deformity, to improve implant alignment, to balance your soft tissue, and treat adjacent joint arthritis. And what you aim for is you aim to restore your radioanatomy of the ankle joint, looking at the centralization of the talus, restoration of the joint line, and restoration of your radioanatomy with the syndesmotic area, Shenton line, and fibular space, what you want to achieve during your surgery. But it's not only that, you have to be able to implant a device looking at the low mechanical axis, but also looking at the foot, which is underneath it. So you have to look proximal and distal to have a stable aligned ankle prosthesis in relation to your low mechanical axis and to your foot. A way to prevent also complications is probably classify the deformity or the arthritis that you're using. And if we want to speak a common language, so I think that the BOFAS classification, although it's not perfect, is probably a good primary classification to look at what you're treating. And with additional surgeries, you probably need to address the deformity and the stability of the ankle prosthesis. Alignment matters, and we're able to prove it. We have 2 articles looking at alignment. One article was looking at cyst formation in post-op phase and long-term outcome. And what we actually found is that there's a direct relation to residual malformation and cyst formation. So the bigger the deformity you have after implantation, the bigger cyst you get. And also a varus malformation will get medial cyst, and a valgus malformation get residual lateral cyst. And that prevents also the importance of the tripod function of the foot and ankle after implantation. The second study that we were looking at is at the post-op phase, where we're looking at the wear debris after implantation. And there is a direct relation with post-op alignment and wear debris of your polyethylene, and also post-op stability has a direct relation to augment wear debris of your implant. So polywear can be a predictor of failure, but it also can be a way to look at how the implant survives at the long term. If you go then in deformity correction, initially it's thought that more than 10% will be an absolute contraindication for total ankle, but recent literature shows that even severe deformities can have similar outcome and similar midterm survivorship, but that means that you need to plan for additional surgeries. So the planning is probably important. It's not only the coronal deformity, but also the sagittal and rotational deformity, which is important. And then you need also your joint debridements, Achilles tendon and gastroc release. In rotational deformities, you can use the implant to derotate the implant to be able to address some rotational deformities. And sometimes you need stage osteotomies to be able to address the sagittal deformities. What we know about additional procedures, it increases operative complexity, but there's no major increase in short or long-term or short-term complication rates. It gives you a longer operation time, but not increase in systemic complications. So that's a good thing that we have to know. And if we do go then in varus ankle, what we plan our incisions, and we plan mostly 3 incisions if you go for a varus deformity, which is actually considered as an additional surgery, and we try to avoid a medial malleolostomy. So how we attack a varus ankle, we will start with the posterior medial incision in front of the tib posterior. We release a posterior malleolus to the lateral side. We release a posterior capsule, and then if necessary, afterwards, we can use this incision to lengthen the tib posterior tendon if necessary. Then we go to the lateral side because especially in the varus, you sometimes have a lot of osteophytes. The osteophytes will follow the traction of osteophytes, and they will follow the ligaments at the lateral ankle. So we make a curved incision over the fibula, where we can open the capsule, and then we can debride the lateral side with the joint, taking off the osteophytes of the fibula and the talus. So we were able to reduce the talus into the mortise. And then we go to our anterior incision. The anterior incision classically for the implantation of the prosthesis, but also to do the necessary releases. And we start with a localized talonavicular joint release, which is over the top of the joint. We open the talonavicular joint to the medial gutter. So we see the complete opening of the medial gutter, and then we can decide to do a deltoid peel and release the medial side with the release of the deep deltoid ligament if necessary. And if you need to release it, you need to release completely the deep part of the deltoid to be able to reduce the talus into your mortise. The way to go over top and to the medial side, you don't comprise the vascularity of your talus, which is actually a good point to address this deformity. And this is what you want. You want before implantation, you want to be able to reduce the talus into the mortise. If you don't do it, was something I learned from Kris Blondell. If you are not reducing the talus, then your cuts will be wrong, and your implantation of your implant will also be of grit. Example of this is look like quite easy deformation in sagittal and coronal plane, but the surgeon was not able to reduce the joint very well, and there was a rapid onset of osteolysis and subsidence and loosening of the implant. But it can be more complex. If you can see in this case, the patient came with a deformed joint after a triple arthrodesis, and then you have to think about how to address it. You know you have to do soft tissue balancing, but probably because also of the stiffness of the hindfoot and the Chopard joint, you need to change your implant choice. So actually what we did here is we decided after the planning, and you see that there will be 20 degrees of varus. We did the release on the posterior medial, on the lateral side, and then we took a stemmed implant to reduce the forces and to be able to have a more primary stability. You see that at the end we had to do a stabilization. So we did a lateral ligament reconstruction, and the screw that you see on top of the implant is because of its quite osteoporotic bone. When we put the stem inside, the stem was chiving off of the direction that we want to, so we pushed the stem back with the screw to have a good alignment of the stem afterwards. So the lateral stabilization is probably important because, especially in varus, it will fight against rotational instability. So we always use a lateral incision, not only for the debridement, but also to do a kind of a prostrum afterwards. So if you have enough soft tissue, we do a direct repair. And if not, we do an anatomical reconstruction with an autograft. And at the end, then, if you still have a residual hindfoot varus, then we do a malar osteotomy to address the residual varus. And if you have a cavus position of the foot, then we probably do an elevation of the first ray. But sometimes you still have a problem with rotation, and then we do a shortening or derotation fibrosis ostomies to address the final touch to adduce it. So this is our Malherbe osteotomy. It's quite easy osteotomy. You don't need a big incision, and you take a wedge out. With this wedge, you can reduce the hindfoot position, and you fix it with one screw, which is up enough. This is a case before we had prophecy, so it's done with an external guide. It's a professional football player. At the end, after his career, he had at the right side, he has an ankle arthrodesis done and had a painful arthritis, as you can see in the coronal and sagittal plane deformity. And we were able to redress it even without prophecy. It's probably not perfect, but it's done in 2016, so he's 10 years out of surgery and still happy with the result of his ankle prosthesis. If you have a medial instability, then you have to think what causes the medial instability. It's not only medial instability. It can be a valgus ankle deformity, hindfoot valgus, fibrillar malunion or shortening, or it can be a medial malleolar insufficiency. And then you have to think that you have to do the bony correction first, so it's not purely ligament. If you have a flat foot disease, then it's another thing. Then you have an unstable foot underneath your ankle prosthesis or your ankle joint, and you have to be able to address the unstable foot deformity in relation to the ankle joint. So another case of a hindfoot valgus deformity, and if you look at the valgus in the hindfoot, you see a break in the meathery line. But if you look at the MRI scan, then you see that the most of the pathology is at the tibio-talar joint and less at the midfoot joint. And so we were looking at how to plan this, knowing that if you have a flat foot, the total ankle will not address the medial instability. It will not address the correction of your meathery line. So it will also not address the tripod function. So we decided to do a lapidus with a calcaneum shift and a medial reefing to be able to address the medial instability. We put our ankle prosthesis, and as you can see, we derotated the implant. We aligned it to the medial gutter because an internal rotation of an implant will fight against valgus, so it will stabilize the valgus deformity of the ankle joint. So if you have those complex deformities where you start, you typically will start at the apex of deformity and then you go from proximal to distal. And they can be very proximal. There was a professional basketball player who came to us with a painful ankle deformity. You see it's a massive coronal deformity, but he also had a meniscectomy done at his knee. His knee was less painful than his ankle joint, but still it was symptomatic. So we first sent him to the knee guys who put on the total ankle inside. And then he came back to us with this deformity. You see it's a coronal and sagittal plane is quite okay. He has some adjacent joint disease, still navicular and subtalar joint, but clinically they were not so painful. And so we were able to put an ankle prosthesis inside. You see that we did some work on the syndesmotic area. That's because it was quite difficult to implant. And when I implanted in, there was a fracture of the chapeau. So, and with the Infinity, it's important to stabilize it. So I put the screw inside and throw a tightrope inside to stabilize this syndesmotic area. And it's still quite good. So if you go then in those difficult, do you stage it or do you go in one stage? If I'm capable to do it in one stage in the foot and ankle, then I will do it in one stage. If I have a more proximal deformity in the metaphyseal or more proximal or in the femur, I will stage it, except in COFAS 4, when I have to do arthrodesis, like a subtalar or triple arthrodesis, I will stage it. When I have a complex flat foot deformity, I will also stage my surgery. And the reason why for a more proximal disease, that you stage it is this is a quite complex deformity after a pylon fracture. The fact to readdress the sagittal coronal deformity, it can have a 5-year survivorship of your osteotomy. So actually, and that's what's happening. This guy was operated 4 or 5 years ago, and he's still good, still pair with his native ankle joint without the need of an ankle prosthesis. But sometimes you can have an hyperstructural deformity with a fracture. So this guy came to me with a pseudoarthrosis of a pylon fracture, an anterior pylon fracture, and he didn't want a fusion. So we had a long discussion with him, and we did a graft for the anterior plafond reconstruction with an autograft. We waited 6 months until the autograft to heal. We did a CT scan looking at the deformity and looking at the healing of the pseudoarthrosis, and then we planned our ankle prosthesis. And you can see he's 5 years out of surgery with a quite good mobility, pain-free, and quite happy with the result of his ankle joint. Sorry, I have a problem.
It's okay, Kris.
Okay, it's okay now.
Yeah.
So what we actually try to do is we try to build an ID for all of our patients. I will put every information that I have of a total ankle. I will put it in an Excel file where we look at the knee joint, we look at the foot position, we look at the foot deformity, we look at the degrees of deformation in varus and valgus. So every information that I get out of my X-rays and out of my plan, I will put it down in a Excel file, and then from there I try to plan my surgery. I will write down every additional surgery that I want to do, and at the end I will look at then what I did in surgery. I write down the implant size, what we did actually in surgery, and then during the follow-up, I will also note the complications or the outcome and the prompts that I have for this surgery. And that means that I look at the patient factors, I look at my standard X-rays, I look at MRI, I look at my full weight-bearing CT scan, I look at my prophecy scan, and all that information I put down in the flowchart. And afterwards, at 6 months, also they get a new weight-bearing CT scan, look at the implant, look at the implant position, and also what I did. Did it actually address the deformity? Is a surgery that I did, and the additional surgery was able to correct the deformity that I plan to. And that did learn me that is a bit the way how I treat it now. So I will start, as mentioned, with all the releases. I will try to reduce the bony impingement. I will try to reduce my talus first, then I only go for my total implant, and then I correct from proximal to distal the rest of the deformities. And at the end, I will stabilize my ligament structures, and or necessary do some lengthening if necessary to on the medial side. And this learned me a lot. I mean, going from the star ID, going into preoperative planning, trying to see what I realized in my surgery, and looking at my post-man outcome in imaging, but also complication and prompts at long-term follow-up. So take home, I think it's important to have a patient selection, implant selection. If you want to have a successful total ankle, you have to be able to have a stable, well-aligned ankle joint with a plantar aligned hindfoot and forefoot. And I think it's most important, depending what implant that you use. I know there is a quite philosophical discussion between a implant that uses a talar first or a tibia first. The Infinity is more a tibia first, but the Cadence and the quantum prosthesis are more talar first, where the talus will guide the prosthesis. But still, the implant will, for me, will work as a spacer in a well-aligned and well-stable ankle joint. So the first thing to do is to reduce your talus into the mortise before you implant your prosthesis. Perfectly, you should plant it perpendicular to the lower mechanical axis and the components parallel to the floor. You need think about multiple incisions. If you cannot obtain alignment and stability, then stage your surgery, even if you're not able or you're not, you think you're not capable of doing it in one stage. Don't be afraid to stage your surgery. Think about the subtalar joint, because that's something, and the chopard joint, you want to, as much as possible, keep them. After implantation, look at balancing and stabilization. So plan your surgery well in advance and try to use an ID card. I mean, I learned a lot keeping all those information for myself and looking at what I did during surgery, what I planned, give a good or a bad outcome. So that was what I want to say. If you want to learn more, there is the Ankle Academy in Newcastle in the month of May. So thank you for your attention.
Thank you so much, Kris. That is amazing, really nice, challenging cases you presented, and I'm sure the audience would like to have some questions which we can take after next speaker. So I would now like to invite Joris Hermus, who is based in Maastricht University. Um, I don't know why I'm showing Maneesh Bhatia, um, and is also the honorary secretary of EFAS. Again, he has a huge interest in ankle replacements and has done a PhD recently on complications in ankle replacements, ankle arthroplasty. So, no better than Joris, who can talk about the management of complications following ankle arthroplasty. Over to you, Joris.
So good evening, everyone. Thank you for the invitation. Or what? Yeah, now I'm sharing. It's truly a pleasure to be here. Special thanks to Maneesh to be inviting us, and I'm honored to be presenting together with Kris. So my name is Joris Hermus. I'm a foot and ankle surgeon from Maastricht University Medical Center, the Netherlands. As already mentioned, I'm an executive officer of EFAS, but I'm also a board member of the Dutch Foot and Ankle Society, which these are my disclosures. And I'm one of the first certified foot and ankle surgeons from EFAS. So today, I would like to guide you through the complication of arthroplasty by asking a few key questions. I'll make it smaller. What are actual failures? Which complications are most common? And how do we classify them? And what kind of failures, and can we rescue them? And I will point out a few patients already mentioned by Kris. So what are our failures? I already did a survey about the necessary registries, especially within Europe. And we see in the Scandinavian national registries that they have a survival rate between 70 and 74% in 10 years, nonetheless with low annual numbers. The German registry, they indicate a better survival rate, although the registration is voluntary. Our own Dutch registry does it a bit better. The only thing, it's only have a follow-up of 3 years. And the most comprehensive national data is here from the UK, with a survival rate of 6.2% in 10 years. And it's very important that we recognize our complication rates, because by decreasing them, probably our survival rate will also improve. So what are our complications and which occur during ankle replacement? So we performed a meta-analysis that showed that operative intraocular fracture and debridement are the most common complications. You see with an occurrence of almost 6% each. But how do we classify these kind of complications? So complications can be divided by timing of their occurrence, such as intraoperative, but also postoperative. Another manner to divide them are causal-related, such as implant-related complications, patient-related or surgeon-related. So the most common complications involve intraoperative are a fracture. These are iatrogenic. They are most of the time linked to an inadequate exposure of the jig or the size of the resection guide, along with the improper use of the saw blade. However, with the current guides, this will probably occur less than before. So according to the postoperative complications, they include like a deep wound infection, postoperative fracture, instability, malalignment, and impingement. But maybe they can also be seen as surgeon-related. So complications can be divided, like already mentioned, implant-related. Are they related to the comorbidity of the patient? And are they caused by the surgeon? Archangelo He conducted a meta-analysis. They demonstrated that a non-anatomic mobile bearing and hydroxide-coated and non-tibial stamped total ankle replacement are linked to cystic lesions. Cystic lesions also occurred a bit more around the patellar component, and a malalignment also occurred more significantly in the mobile bearing group. And as you can imagine, the reoperation rate was also a bit higher in this group. So complications which could be occurred by the surgeon themselves or the technique are, for instance, instability, impingement, or malalignment. Another how you can classify the complications is Glaze group classification. They assess the risk of total ankle replacement failure. For instance, the low risk, low grade are the interrupted bone fracture and the wound healing problems, while the medium grade leads to a failure rate less than 50% of the time, like a subsidence or post-operative bone fracture, while a high grade leads more to a failure rate of higher than 50%, as you can imagine, with deep infection or septic loosening. So how do we manage these kind of complications? So fracture management, I already mentioned that we are sometimes the reason that we cause the fracture. Lazaridis, he mentioned even that you don't need to address all fractures during the surgery. Nonetheless, I prefer them to address them during the initial surgery. So if they occur during like a medial malleolus fracture, I fix them with the 2 cannulated screws. When the fracture is a bit more vertical, I use a plate. And for talar fracture, I use a headless compression screw. As prevention, postoperatively, for a medial malleolus fracture, when the width is only 9.43 millimeters between the implant and the cortex of the medial malleolus, it's advisable to use 1 or 2 preventive medial malleolus screws initially. So concerning instability, they can be, for instance, caused by distortion of the patient, making it so traumatic. However, I believe that it can be also iatrogenic, occurring from releasing too much. Releasing is for sure sometimes necessary for tight balancing during the surgery, but you can also overdo it. For instance, this could be seen as a traumatic one. Nonetheless, this type of prosthesis was performed on both sides of this patient, and I think this surgeon releases a bit too much on the medial side. Besides that, you see, like already mentioned by Kris, there is also a slight valgus of the foot, so there's more to balance. Nonetheless, I revised it and I reinserted the deltoid ligament, addressed the pes planus, and performed an internal brace locally. Instability management, in general, fixed bearing gives a bit more stability than mobile bearing. For sure, sometimes it's necessary to release the ligaments, but also look in general what it does overall. And sometimes I learned this technique from Doets. There are several ways to perform to address the varus tightness or the balancing perioperatively, but a medial malleolus osteotomy is also an option. So impingement was one of the most common complications we found in our meta-analysis. Impingement is nothing more than pain in one of the gutters, because caused by friction, most of the time on the medial side. Schubert mentioned that impingement could occur due to oversizing of the implant, sometimes also by subsidence per ossification, and also uncontrolled varus or valgus thrust. Nonetheless, Nayevi of the Goldberg group, he showed that impingement was more likely to occur when the internal rotation was greater of the tibial component. And this also improved when they addressed the correction of the rotation in the right angle. And this is something we can address by design. So how to prevent and manage impingement? It's very important to prevent too much internal rotation. So be aware of this, look at the foot, and in general also do this pre-operative planning like Kris said. Do not oversize too much the design, remove periarticular ossification, and if necessary clean the gutters. I will do this myself pretty aggressively. And post-operative, sometimes it's very difficult to diagnose where the pain comes from the patient. Then sometimes a local infiltration in the gutters can help diagnose exactly where the pain is coming from. SPECT-CT can show the hotspots, and for me it's 1 + 1 is 2. Necessary when the local infiltration comes and I see a hotspot on the medial side and no loosening of the implant or rotation problems, then I'll clean the gutters. And then let's also be aware that there is not a rotation problem. So malalignment, we ourselves did a finite element analysis showing that the malaligned total ankle replacement had a higher failure rate for when we put the valgus or the talus component too much in stimulus. So when you do this, you see this already, that this tendency occur during your first surgery, maybe you need to recut it. Deep infection. We know in our meta-analysis that it occurred only 1% of cases. Nonetheless, there are also other reports that the infection rate is between 0 and 13%. The difficulty is always, do we recognize it and do we admit there is a problem? In this regard, try to find your worst colleague in your group, take him to your patient and ask them, what do they think about this case? And they will be honest probably if there's really an infection, and then did you admit that there was a problem? Nonetheless, also the European Bone and Joint Society, they gave a guideline or advice in this regard when you really can suspect an infection. So sometimes you can take cultures and have how much leukocyte count, but as you can see, it's not always trustworthy. But when you have positive cultures, then that's for sure an infection. And if there's an fistula, no doubt there is an infection. So then you need to act. So in case of an infection, what do you do in the acute phases? You do in there debridement, antibiotics, and implant retention. In our hospital, then we debride it. We take at least 3 to 5 cultures. In one of those, it's a sonification of the polyethylene insert. Why an equal number? Because we want to have a winner of the match. That's one of the things. We exchange the polyethylene insert. We give antibiotics, in our case, as broad as possible. So vancomycin and ceftriaxone. We also irrigate a lot with almost 6 liters fluid, because one of my infection orthopedic surgeons, he always says, and his phrase is dilution. So antibiotic therapy, it was advised by the Americans. Use it 6 weeks in prosthetic joint infections to give Rifadin until the wound stops draining, and this is especially raised by a formal case of Staphylococcus. In the Netherlands, we become more and more aggressive in this regard. So we don't do 6 weeks, we even give them 12 weeks. And there is currently a randomized clinical trial going on if you really need to give Rifadin in case of is as follows. So if there's an infection within 6 weeks, and when you have a late infection, then the symptoms need to be less than 3 weeks. So if there's no fistula, there's no loosening and no difficult to treat bacteria found, then we perform a DARE procedure. Most of the time it cures with good results. Nonetheless, not all patients can be cured with this procedure. At most we do their procedure, but afterwards then you need to do differently. If there's a fistula or loosening or difficult to treat bacteria, the prosthesis can't be saved. And also when the chronic symptoms are longer than 6 weeks, what do we do? Sometimes we try to do a one-stage revision, especially when there are no large bony defects or no difficult to treat bacteria, but also no soft tissue damage, because then otherwise you need to have a plastic surgeon who can do the reconstruction of the soft tissue. Then otherwise, if it's not possible, we try to have a look if it's possible in a 2-stage surgery, and if replacement is really not possible, then depending on the defect, the large defects or not, and the soft tissue, we decide to do an arthrodesis. And in worst case scenario, it's already reported, sometimes even an amputation. Yeah, it didn't occur yet at my group. And if surgery is in generally not possible because of the comorbidity, it can be helpful to use to give lifetime antibiotics. So these are the difficult to treat bacteria. You need to be aware of when these are the microorganisms you don't want to find, because they really adhere on your implant, and then you can't get rid of. So sometimes it's very time to change ourselves in our thinking in this regard. So do we need to change our aspect of treatment? Concerning managing the deformities in the ankle replacement, malalignment can be addressed even after performing the total ankle replacement. Sometimes it's tibial osteotomy, and in valgus you can sometimes have, if there was already shortening of the fibula in this regard, and try to save the ankle implant. This is only possible when it is a stable implant, and this you really need to have, like, for instance, PET-CT can be helpful in this regard. This is also with varus malalignment. As you can see, this starts sometimes with a medial release, but most of the time, if it's a stable implant, you need to do an osteotomy above the implant in this regard. But as already mentioned by Kris, not only look supramallear, also inframallear, because sometimes you need to readdress the balancing also of the foot, like pes planus or varus cavus. So what kind of failures can occur and how can we rescue them? So these are the failures most of the time found. These is that 10 to 30%, like already mentioned, can cause a failure in 10 years. So in case of a fracture, what you need to be aware of, that it is not because of cystic lesion or loosening in this regard, because then you need to do a revision. Therefore, Lazaridis, he said that almost every talus fracture post-operative on the long term is a cause of loosening. Therefore, you need to revise it or do a fusion. While in a medium malleolus fracture, in his way, when the implant is stable, then you fix it with sometimes a plate or screws, depending on the how vertical the fracture is. So malalignment, here again, be aware of that's not subsiding or cystic lesion caused by loosening. If that's the case, you need to revise totally the ankle implant. Otherwise, you can readdress them according the following treatment scheme. If that's in the case of a valgus and a varus malalignment, but we need to be aware of when we do this kind of surgery, we most of the time have one shot to do it. And if we are not able to do it in this regard, these kind of PSIs can be very helpful. But if it's not very common in your center, please refer them to the right center in this regard. So cyst formations are already addressed. As you be aware of, you always need to determine if the cysts are caused by osteolysis and therefore also already loosening, because most of the time also PE particles are identified in the cysts. Nayevi already mentioned that most cysts can be found already perioperatively during the surgery. It's very important that you redress them during that surgery. Afterwards, postoperatively, on the long term, for sure you can decide to do grafting of the cyst, but really be aware of that there is no loosening of the implant, because 40% of the cases need to be revised in general. So, like already mentioned by Kris, patient stratification, we performed ourselves also research of the Dutch arthroplasty registrar, showing that the high BMI and a higher age risk for failure, but also previous osteochondritis dissecans treatment. The same was found also in the NHS and NGR data, that higher risk is also higher for failure, a BMI in the same case, but rheumatoid arthritis has a lower risk of failure compared to osteoarthritis. So in general, we need to be aware of when a complication occurs, it's very difficult for the patients to handle. And what we saw, that it's more difficult for the patient when there is already anxiety or depression preoperatively. So this means also that we need to train our patients already before the surgery to kennel and hope, and that their expectations are really coherent what we think that an ankle replacement in the future can do. So in general, like already mentioned also by Kris, documentation is very necessary. But as you know, by good documentation, finally you can see that the ankle replacement can be the best outcome for several patients, but not for all. Thank you very much. I hope to see you once also in Maastricht, and I would advise you to come in Maastricht in September to our traumatology course. Thank you very much. Maneesh, you're muted.
Thank you. Thank you very much for nice presentation, Joris. And now we will start the discussion bit. And we have one question which I would like to ask both Joris and Kris, maybe Joris first. So this is a question from Matwali Syed Ahmed about your experience in osteoarthritis of the ankle with ipsilateral knee arthrodesis. So both of you can give your advice or suggestion about this unusual scenario.
With a knee arthrodesis, I have to admit, I did a lot of research in this regard, but I never saw this kind of in the articles, and it didn't occur in my own practice, I have to admit. So I find it very difficult, because also the forces will be a bit more different in this regard. So I don't know if an ankle replacement in this regard will be the best solution, but maybe Kris has a better experience in this already.
No, I never came across a knee arthrodesis. I know sometimes it's done for an infection, but in Belgium it's very rare. I mean, everybody get a prosthesis. But on the other hand, what you do see is that that people after a knee replacement, they're not happy with an ankle arthrodesis. So I can imagine that if you block an ankle, if you do an arthrodesis after a knee arthrodesis, then you get a very stiff limb, and patient won't be happy. But it's an unusual scenario. I've never seen it. No, sorry.
Thank you very much. Yeah, I agree. You don't want to do arthrodesis both at the knee and ankle. So probably ankle arthroplasty would be the right thing. Matwali says that he can send us the X-rays, and yes, by all means, send me the X-rays, and I will share it with Kris and Joris, and they can advise us. Yeah, thank you. The second question is from Rebecca Lewis to Joris. What is the rationale of 12 weeks of antibiotics as against 6 weeks?
The thing is, what we know that when there is an implant or bacteria is already on site, it can adhere very long on the metal itself. And what we saw already from our own experience, we can't get rid of them after 6 weeks. So we become more and more aggressive in general when we can't, for instance, remove all the implants, even when you do an infection case after the triple arthrodesis and a screw has broken. Even that part, when it's left in, we treat them afterwards with 12 weeks antibiotics. It adheres too much, too long on this kind of metal.
But Joris, can I ask, then you only give the Rifadin, no? It's not the double, or you do the double antibiotics, or you just keep your Rifadin for 12 weeks?
No, in the beginning we give, like I mentioned, vancomycin and ceftriaxone. And then when we know what comes out of the cultures, then we smaller our spectrum. For instance, if they're clindamycin or in Staphylococcus in combination with Rifadin. But most of the time we start between 7 to 10 weeks, we go to oral medication. But then in combination with the Rifadin. But as mentioned already, there's now a randomized clinical trial going on with the knee and hip arthroplasty. That the question is, do we need to combine it with Rifadin in case of Staphylococcus? So probably these kind of results will show that maybe it's not necessary to penetrate through the biofilm.
Thank you. One question which I would like to again ask both of you and Kris. I noticed that your threshold for doing varus deformity is much higher. So your varus deformity you can tackle up to 25 degrees, 30 degrees, whereas valgus you say 15 degrees. The anecdotal teaching is valgus is more tolerable. So, and people are worried about varus deformity more. But you think that it can be handled up to quite significant degrees, 30 degrees or so.
Yeah, my experience that, well, you see more varus than valgus deformities in ankles, and that the varus ankle is more stiff, so you can get rid with a lot of more deformities if you're able to correct it and if you're able to stabilize it. But that's why you need multiple incisions, I think, to address this deformity. A valgus deformity is probably another kind of disease. It's more people with are more lax. They have more supple joints. And there you have to be careful with the number of incisions that you do. They're more forgiving but it's also a wrong concept that you use your polyethylene to stretch out the ligaments and to stabilize a valgus deformity. It's something that you have to be aware of. What you always read in literature is that you overstuff your valgus deformity with your polyethylene, but then you change the joint line, and at the end, I think the outcome is not so good. The varus deformity, it's easier in my hands than a valgus deformity, even if the outcomes are better in valgus in literature than in varus.
Thank you.
And the occurrence
Joris,
for
do you want
valgus
to?
is also less. And in this regard, varus arthritis, as you know, is caused by most of the time because prior instability already on the lateral side. We did a finite element analysis, which showed even though valgus is more tolerable, nonetheless, it's very important not to put the tibial implant in valgus, because we saw in the finite element analysis that you get a higher failure rate if you put it a bit more in valgus. So therefore, maybe even slight varus is even better. In general, neutral is best, but valgus or posterior alignment of the talus, those are really a higher failure, have higher failures in this regard.
Thank you. And regarding tackling the deformity, you did mention about, I mean, Kris, you said that you rely mostly on deltoid release and you don't mind even in extreme deformities to go for deep deltoid. But then obviously we talk about instability. So what's your experience that you release too much? Can you have problems?
No, I've never seen a problem when the problem is if you don't release your deep deltoid, then you get a recurrence of your virus. But if you keep your that's why the deltoid peel is so powerful. You keep your superficial deltoid intact, and it will put itself back in a good position because you do a deltoid peel. It heals back, but you need to cut your deep deltoid. If not, you get a recurrence, and I've never seen an instability afterwards.
Unfortunately, I saw, as you shown already one, and that was really, and on both sides even.
So that brings us to next question. We have a question from audience about tips of doing medial malar osteotomy and fixation to narrow the mortise on the talar component and prevent the subluxation of the insert because the mortise is wide around the talar component, they say. So Kris, do you do medial malar osteotomy first of all, or you?
No, almost never. I don't get the question. That means that can you repeat it?
So the question, I'll read it exactly as asked. At completion of the total ankle replacement, the mortise is so wide around talar component. What are your tips in medial malar osteotomy and fixation to narrow the mortise on the talar component and prevent subluxation of insert?
Well, that's probably because the reduction of the talus was not done before. I will never implant a total ankle if I'm not able to reduce my talus into my mortise. That means that you need to do everything preoperatively before you do your implantation and not look afterwards, because then you're in trouble. It depends on what you see, but the purpose is to do your realignment surgery before you implant your ankle joint. There is some cases of syndesmotic instability, of course, but that's also proven if you have a fixed bearing implant, then it can be forgiving for a syndesmotic instability. So if you have a mobile bearing, then you are in trouble. So it depends on what you want to, what implant that you use. But the most important part is to do the reduction of your deformity before you implant the ankle joint.
Thank you. Joris, do you want to add anything?
Yeah, I can tell you something about the medial malleus osteotomy because I was taught in this regard with dudes. Like mentioned, there are several techniques to realign the tightness. Kris releases the deltoid. I do it, for instance, by medial malleus osteotomy. There are several techniques. Beat Hinterman put it a bit more horizontal than I do, but then when you do the correction, then you get an opening on in that regard. I do it a bit more vertical in this, and you get really a shift. But it's very important that you don't do it in the alignment of the ankle implant itself. It needs to be a bit more medial from that, and therefore you slide downwards, and then you can. I really see a good balancing in this regard, but there are several ways to get to Rome, as you know, and that's also with medial ligament balancing. It's a kind of belief and how you fix it. And there's, I think right now there's not a literature which one is right or wrong. For me, it's very important that you know the techniques available, and at the end you need to decide yourself what's best in your hands, which gives the best results. For me, it's the medial malleus osteotomy. For Kris, it's different. It's the deltoid ligament release in this regard.
No, I agree. There are always, that's why foot and ankle is interesting. One question I would like to ask about the perioperative protocol. I have never used it and I've not seen it being used in UK. So methylprednisolone at induction. Kris, tell us more about it because does it reduce infections in your practice or does it improve the outcome?
Yeah, I do believe so. I started using it. It's actually the French school who started with it. It's also used in total knee replacement. So actually what it does, it gives less perioperative swelling and less postoperative swelling. So you get less pain, you get less traction on your wounds, and you see a lot of, you see a better outcome post-op. I have less wound problems since I start using it. My operation time, even in a complex case, can be longer without massive postoperative swelling, and even perioperative swelling. You can close your wounds easily without traction if you use the methylprednisolone. But you have to be like a quite high dose. Jean-Luc Best, for example, he gives 500 milligram IV. I give 150 milligram IV because sometimes 500 is quite high. He gives it in a drip. We give it 150 milligram in one shot to prevent the peri and postoperative swelling.
Thank you, Kris. Joris?
Did you ever use, do you always use a tourniquet in this regard? Because what I saw in preventive measurements concerning infection, I see less infection, a wound infection, since I didn't use a tourniquet in this regard, in general, in foot and ankle surgery.
Well, I will use my tourniquet for the initial incision. I will never go longer than 1 hour. After 1 hour, 1.5 hours, I lose my tourniquet, and then it doesn't bleed anymore. But I like to be safe when I start especially if I need multiple incisions. Well, actually, when I use multiple incisions, I will start with my postomedial and lateral incision without the tourniquet, and just when I start doing the anterior incision, I put the tourniquet on. I don't know why. Probably I can do everything without the tourniquet, but I use it on a minimal time just to address and do the incision, and then after 1 hour, 1.5 hours, I will lose the tourniquet.
Yeah, and I started doing without. I really do every even revision, total ankle arthroplasty, and I really saw a decrease in wound infections, and we're trying to report them in the future, the difference between with and without.
And I take it none of you use drains, is it right? Or you use drains?
Never.
No.
Never.
It's an opening for bacteria.
Yeah, no, I've seen some very prestigious surgeons using drains after ankle replacement. So I thought it's not common in UK either to use drain. We've gone away from drain. Well, we are 9 past 9. So that has been an excellent session, really enjoyable, and people will benefit from your experience. Thank you very much for your time once again on behalf of BOFAS and personally as my friends. Really appreciate it for you giving your excellent sessions and talks. Good night, everyone, and we'll see you soon on our next Master Techniques webinar. If you have anything you want me to organize or BOFAS to organize, just send us suggestions. Have a very good evening. Thank you, everyone.
Thank you. Thank you, Manish.
Yep.
Thank you, Manish. Bye.